He sits in the armchair, a piece of furniture that was once a comfort and has slowly become a cage. Arnold's hands grip the worn fabric of the armrests, his knuckles turning white. He's not resting, he's strategizing. He takes a slow breath, bracing himself for the simple act of standing up, a movement he's performed 1,000,000 times without a thought, but which now requires the mental preparation of an athlete before a lift. He pushes. His arms tremble with the effort, but the real betrayal comes from below. As his legs begin to straighten, a sharp, grinding jolt shoots through his right knee. It's a familiar kind of pain, an intimate enemy. A visible wince contorts his face, a silent curse passing his lips. He finally makes it to his feet, unsteady for a moment, and his hand immediately finds the joint, pressing into it, as if he could physically command the pain to subside. His expression is a complex mask of frustration, anger, and a deep, weary resignation. This isn't an acute injury. There was no fall, no dramatic event. This is a slow tide that has been rising for years. It's the unwelcome companion that sits with him at the dinner table, that wakes him in the night if he shifts the wrong way. It's the background static to his life, the reason the world outside his window often seems impossibly far away. It's why he finds excuses when Margaret suggests a walk through the park they used to love, the memory of her slowing her pace for him more painful than the ache in his leg. The simple joy of movement has been replaced by a constant, draining calculation of risk versus reward. He knows the official name for his problem. He remembers the day he was given it, as if it were a formal title. He was perched on the edge of an examination table, the thin paper crinkling with his every nervous shift. The air was cool, smelling of antiseptic. The doctor, a perfectly pleasant man who seemed to be consulting a clock only he could see, held up a large dark square of film to the light panel on the wall. It was a ghostly black and white map of Arnold's own interior. "See this here, Arnold?" the doctor said, his pen tapping a fuzzy, clouded area. "The space between the bones is narrowed. That's arthritis, significant wear and tear." The doctor lowered the x-ray, his face a practiced mask of sympathetic gravity, and then he delivered the 6 words that would echo in Arnold's mind for months. "At your age, it's to be expected." At your age. The phrase didn't land like an explanation. It landed like a judgment, a life sentence disguised as a diagnosis. It implied that his body was not a living, adaptable system, but a machine with parts that were simply wearing out on schedule. That this pain wasn't a problem to be solved, but a condition to be managed, a cross to be borne until the end. Arnold just nodded slowly, the hospital gown feeling thinner than ever. What could he say? How do you argue with the calendar? But as he sat there, a profound sense of powerlessness washed over him. The doctor had given him a label for his pain, but in doing so, had stripped him of any hope for a solution. He felt trapped, not by the arthritis, but by the story he'd just been told about it. He left the office that day with a name for his condition, but feeling more like a victim than a patient, and utterly alone in his search for a way out. I'm Dr. Dean, and Arnold's story, in all its frustrating and disheartening detail, is one I've seen play out thousands of times. It's a script that's followed in clinics around the world, a narrative that's whispered in examination rooms, and it's a story I hear every single day from the thoughtful, concerned people who write to this channel looking for clarity. It's the story of a good person being told that their own body is failing them, that pain is an inevitable tax you must pay for the privilege of growing older. It's a narrative that shrinks your world, reducing your future to a short and deeply unappealing list of options. Powerful pills to mask the symptoms, painful injections to buy a little more time, or major surgery to replace the part that has been officially labeled as defective. It's a story that almost always ends not with a solution, but with a quiet sense of resignation. This channel exists to tear up that script. Our entire mission here at Keystone Health is to look at the evidence through a different frame, one we call the longevity lens. This lens forces us to ask a more profound, more human set of questions. We don't just ask, what does the X-ray show? We ask, what will genuinely improve your freedom, your independence, and your quality of life for the next 10, 20, or even 30 years? It means we stop focusing only on the snapshot of the damage and start investigating the flawed movements that created the damage in the first place. We are here to empower you with the critical, evidence-based information that the healthcare system, in its constant rush, often overlooks or fails to communicate clearly. Our job is to translate the dense, intimidating language of medical research into practical wisdom that you can actually use to have more intelligent conversations with your doctors. And most importantly, our ultimate goal is to guide you back to the one person who should always be the CEO of your health journey: you. It's about shifting you from being a passive recipient of a diagnosis to an active, informed leader of your own care. And that process begins by taking a hard look at the very first assumption that sent Arnold down his path of frustration, the one that seems so obvious it's almost never questioned. So let me state the core thesis of this entire video as directly and clearly as I possibly can, because it may sound radical at first. For the vast majority of people over 60 experiencing chronic knee pain like Arnold, the problem is almost never in the knee. Let me repeat that, so the idea has a chance to settle. The pain is in your knee. The inflammation is in your knee. The stiffness you feel is in your knee, and the damage the doctor pointed to on Arnold's x-ray is without question located in his knee. All of that is real. But the source of the problem, the root cause of that pain and damage, is very likely somewhere else entirely. This is the fundamental, and I would argue tragic, misunderstanding that traps so many people in a cycle of failed treatments. The conventional medical approach is brilliant at identifying and naming the victim. It can give you a high-definition, three-dimensional picture of the crime scene. We can see the cartilage damage, we can measure the joint space narrowing, we can label the condition with precision. Osteoarthritis. We are experts at documenting the aftermath. But the system often completely fails to look for the culprit. And by focusing all of our attention, all of our treatments, and all of our hopes on the site of the pain, the victim, we inadvertently sentence ourselves to a lifetime of managing symptoms instead of solving the actual problem. We end up on a treadmill of interventions aimed at quieting the knee's cries for help, while the true source of the trouble is left unaddressed, free to continue its destructive work year after year. This is the difference between silencing a fire alarm and actually putting out the fire. One provides a temporary sense of peace, while the other saves the house. Arnold was taught to silence the alarm. We are here to find the fire. So in this video, we're going to act as detectives for your own body. Our investigation will have one clear goal: to find the true source of that fire. First, we will systematically dismantle the myth of wear and tear, that disempowering story Arnold was told. We won't just tear it down, we will replace it with a powerful, evidence-based framework for understanding your body not as a machine with failing parts, but as an elegant, interconnected system. I'm going to introduce you to a concept that physical therapists and top-level sports scientists have used for decades, but that rarely filters down to the doctor's office: the joint-by-joint approach. This simple idea is the key that unlocks the entire mystery of chronic knee pain. It will change how you see your body forever. We'll then use this new lens to identify the primary culprits, the parts of your body that are forcing your knee to take the blame. My promise to you is this: by the end of this deep dive, you will not only understand the real reason your knee hurts, but you will also be equipped with an entirely new way of thinking. You'll have a set of clear questions that can help you and your doctor finally start searching for a lasting solution instead of just managing a painful symptom. We'll walk through each of these culprits, but I want you to pay special attention when we get to point number 3. We'll be discussing what I call the forgotten foundation. It's a part of your body you probably never, ever associate with your knees, yet evidence shows its quiet dysfunction is a primary driver of the pain that stops so many people in their tracks. It's a classic case of the real culprit being 2 floors down from the crime scene. And you will definitely want to stick around for point number 5, the core of the problem, where we'll reveal the surprising link between your posture, the way you simply sit and stand, and the immense damaging pressure that gets focused down into your knee joints. For so many people I've worked with, this is the final missing piece of the puzzle that makes years of frustration suddenly click into place. These are the hidden connections the system so often misses. But before we start our investigation into the body, I want to start with an experience that I know so many of you have shared, a moment that often marks the beginning of this whole frustrating journey. Before we dive in, I want to hear from you. It helps us understand what you're going through, and it confirms just how widespread this experience really is. In the comments below, just type a simple yes or no. Have you ever been told that your pain, whether in your knee or elsewhere, is simply due to your age or wear and tear? Please, take a moment to do that now. I ask this because when I read through the comments, and I do read them, something powerful happens. Each yes isn't just a data point, it's a story. It's a person. And together, those responses create a visible community right here on this page. It serves as a profound reminder for every single person watching that you are not alone in this frustration. The feeling that your complex experience is being dismissed with a simple phrase is not your private struggle. It's a collective one. Thank you for sharing that. Seeing this shared reality is the first step toward changing it, and that's exactly what we're going to do now. It's time to replace that old, disempowering narrative with a clear, logical framework that actually explains what's going on. All right, this concept is called the joint-by-joint approach, and once you see it, you can't unsee it. Imagine your body as a stack of building blocks rising from your foot all the way to your head. For this stack to be strong, balanced, and able to move efficiently through the world, it needs a clever design. Some blocks need to be incredibly solid and stable, while the blocks in between need to be mobile, able to move freely in multiple directions. The joint-by-joint approach, a framework developed by pioneers in physical therapy like Gray Cook and Mike Boyle, reveals a simple, alternating pattern in this design. Your foot needs to be a stable platform. The joint directly above it, the ankle, needs to be mobile. The joint above that, the knee, is designed for stability. And the joint above the knee, the hip, needs to be highly mobile. Stable, mobile, all the way up the chain. Chronic pain and injury almost always occur when this elegant pattern is broken. And here is the crucial insight. When a joint that is supposed to be mobile becomes stiff and immobile, the stable joint either above or below it is forced to become unstable to compensate for the missing movement. And the knee, the simple, stable hinge joint, is the ultimate victim of this compensation. This single idea explains why focusing only on the knee is the biggest mistake we make. It's why we end up chasing the symptom. This brings us to our first principle of faulty thinking, the one that traps so many people like Arnold in a cycle of frustration. I call it chasing the symptom. When your knee hurts, it's the loudest voice in the room. It screams for your attention with every step, every stare, every time you try to stand up from a chair. And because it's so loud, it's only natural that we give it our full attention. We do exactly what we're told to do. We put ice on it. We wrap it in a supportive brace. We get cortisone injections directly into the joint. We take anti-inflammatory pills to quiet it down. And when all of that fails, we are told the only option left is to surgically replace it. Every single one of these actions is aimed directly at the knee. But according to the evidence-based logic of the joint-by-joint approach, the knee is just the messenger. It's the fire alarm, not the fire. It is doing its job perfectly by sending a clear, painful signal that something, somewhere in the system, is dangerously wrong. By focusing all of our resources on shutting up that alarm, by icing, bracing, and injecting the knee, we allow the real fire, which is often a stiff hip or a rigid ankle, to keep smoldering and burning down the structure. This is precisely why so many conventional treatments provide only temporary relief, if any at all. They haven't solved the underlying biomechanical problem. They have simply silenced the warning system. And a fire that is ignored doesn't go away. It only gets worse. But this faulty response is only half of the equation. To truly understand the origin of your pain, we also need to examine how your body, in its incredible wisdom, creates the symptom in the first place. This happens through a predictable and powerful process that your body uses to keep you moving, a process I call the compensatory cascade. Your body is a masterpiece of adaptation, but it has one primary overriding goal: to help you complete the task at hand, whether that's getting out of a chair or walking to the mailbox. It will find a way to get the job done, even if it's not the right way. It prioritizes immediate function over long-term joint health. This is a critical vulnerability. If your hips, which are meant to be mobile, have become stiff and weak from years of sitting, your body won't simply give up when you try to stand. It needs that movement from somewhere. So it will hijack the nearest, most vulnerable joint and demand that it contributes motion it was never designed to provide. That joint is the knee. Think about its design. The knee is a simple hinge, like the hinge on a door. It's built for one thing: to bend and to straighten. It is not designed to rotate, twist, or shift from side to side. But when the mobile ball and socket joint of the hip doesn't do its job, the knee is forced to pick up the slack. It's forced to twist and grind in ways that violate its basic mechanics. This is the beginning of the compensatory cascade, a slow, steady accumulation of unnatural stress that leads to inflammation, cartilage damage, and eventual breakdown. This initial compensation, however, is rarely where the damage stops. It's just the first domino to fall in a much longer, more destructive chain reaction. This leads to the third and most dangerous principle, what I call the pain cascade. This is the biomechanical version of the slippery slope we often discuss on this channel, where one small, seemingly isolated problem triggers a chain reaction that spreads dysfunction throughout your entire body. It is insidious because it starts so quietly you don't even notice it. It might begin with something as simple as a minor loss of mobility in your ankle. To compensate, every time you walk, your knee is forced to wobble slightly inward, a damaging movement a physical therapist would call valgus collapse. This tiny wobble, repeated thousands of times a day, puts a grinding, unnatural strain on the ligaments and cartilage on the inside of your knee. Your body, in its attempt to protect the now unstable knee, instinctively tightens the powerful muscles around your hip, but this protective measure backfires. Now your hip, which is supposed to be mobile, has become stiff. And a stiff hip makes the original knee wobble even worse. The problem feeds on itself, creating a vicious cycle of compensation and dysfunction. Eventually, this crooked alignment doesn't just stay in your leg, it travels up your spine. One day, you bend over and feel a twinge in your lower back. Years later, you find yourself in Arnold's position. You have ankle pain, chronic knee pain, hip stiffness, and a bad back. You end up seeing 4 different specialists, each looking at their one piece of the puzzle, running tests on their specific joint, and never once realizing that it all started a decade ago with a simple loss of mobility in your ankle. That is the devastating power of the pain cascade. It's this end result, the visible damage on an X-ray, that gets a convenient but deeply misleading label. So let's start with our first major point, the one that forms the foundation for so much unnecessary suffering. We must dismantle the myth of wear and tear. This is the idea that your joints are like the tires on a car, with a finite amount of tread that inevitably grinds away with every mile traveled. It's a simple, mechanical story, and it's one of the most disempowering narratives in modern medicine. While it contains a grain of truth about the effects of friction, it completely misses the more important, more hopeful story. Your body is not a machine. It's a living, adaptive organism. The right kind of stress, the right kind of movement, actually nourishes your cartilage and signals your body to repair and strengthen itself. The problem is almost never use. It's dysfunctional use. It's asking a joint to do a job it wasn't designed for, day after day, year after year. This distinction is everything, because when we believe the simple story of wear and tear, it leads to fear, inaction, and a shrinking world. To understand the profound human cost of this one simple myth, we need to look at what happened to Margaret. In her late 60s, Margaret was the picture of what we all hope for in retirement. She was an avid walker. Not a competitive athlete, just someone who found deep joy and a sense of freedom in moving through the world on her own 2 feet. Her daily walks weren't a chore, they were her meditation, her social life, her connection to the changing seasons in her neighborhood. It was the simple habit that kept her mind clear and her body strong. One Tuesday, on a familiar route, she felt a dull, persistent ache begin to bloom on the inside of her right knee. At first, she dismissed it, a minor twinge. But it didn't go away. Over the next few weeks, it sharpened into a constant, unwelcome companion. The joy of walking was slowly being replaced by a cautious anxiety. So she did what you're supposed to do. She made an appointment with a well-regarded specialist. The appointment was brief, efficient, and utterly devastating. After an MRI, the specialist called her into his office. He didn't sit opposite her. He stood by the light box on the wall, creating an immediate sense of authority and distance. He pointed to a ghostly image of her joint. With a grave, serious expression, he delivered the verdict. "You have the knee of a 90-year-old, he said, his tone leaving no room for discussion. "There's significant cartilage loss here. It's classic osteoarthritis." Margaret was stunned into silence. The knee of a 90-year-old? The phrase felt like a brand, but the doctor wasn't finished. He looked at her chart, saw her listed activity, and made the connection that seemed obvious to him. "You need to stop walking so much," he advised. "You're just grinding it down. You're accelerating the wear and tear." Margaret walked out of that office fundamentally changed. The very thing that had defined her health and happiness was now being blamed for her body's failure. The diagnosis wasn't just a label for her pain, it was an indictment of her lifestyle. The story she was told was simple. Her knee was a worn-out part, and her favorite activity was the cause of the damage. And so, she began to believe she was fragile, broken. The wear and tear narrative became her internal monologue. She started avoiding the stairs. She turned down invitations from friends for walks in the park. She became fearful of the very movement that had once sustained her. And here is the tragic irony. As she moved less, the stiffness and pain only got worse. The muscles around her hips and legs began to weaken from disuse, providing even less support for her knee. Her world, once as wide as the horizon on her favorite walking path, began to shrink. It shrank to the size of her house, and then to the distance between her living room and her kitchen. She had been given a diagnosis, but what she had really received was a prescription for decline. Margaret accepted her doctor's verdict as fact, because why wouldn't she? It came from a position of authority and was backed by a high-tech image. But what if that interpretation was wrong? What does the actual scientific evidence say about the connection between what we see on an MRI and what a person actually feels in their body? The answer is not just surprising. For millions of people trapped in a story like Margaret's, it is profoundly liberating. A landmark study in the highly respected British Journal of Sports Medicine looked at the MRIs of a large group of adults who had no knee pain at all. They weren't patients, they were just regular people living their lives without any symptoms. What they found should be on a billboard outside every orthopedic clinic. A huge percentage of these completely pain-free people had findings on their MRIs that would normally be diagnosed as serious problems. Cartilage defects, the very definition of wear and tear, were found in 43% of people over the age of 40. Meniscal tears, a common justification for surgery, were found in 19% of women and 32% of men over 50. Again, these people had zero pain. The scientific conclusion is inescapable, and it's one of the most liberating truths in all of medicine. The structure of your knee on an image does not reliably predict the function or the feeling of your knee in real life. As one brilliant researcher put it, these findings are often just gray hair on the inside, a normal, expected part of the aging process, not a sign of disease or a sentence to a life of pain. This evidence fundamentally reframes Margaret's story. The diagnosis of wear and tear wasn't a diagnosis of her pain, it was simply a description of her age. It told her nothing about why she hurt. The real risk here isn't the wear and tear itself. The risk is what happens when we believe that's the whole story. It's the danger of the nocebo effect, the dark twin of the placebo, where the firm belief that you are damaged and fragile actually creates disability. For Margaret, this belief became a self-fulfilling prophecy. The fear of movement, prescribed by her doctor, led to a real measurable loss of muscle. The powerful gluteal and quadriceps muscles that are meant to act as the primary shock absorbers and stabilizers for the knee began to atrophy. This weakness made the underlying instability around her knee joint even worse, which in turn created more pain. It's a devastating feedback loop. The belief in damage leads to inaction. The inaction leads to weakness, and the weakness validates the original belief that the knee is failing. And this is the exact point where a patient is often guided towards the next logical step in the conventional model: surgery. Specifically, a procedure like arthroscopic surgery to clean out the joint. It sounds so reasonable, like tidying up a messy room, but the evidence here is overwhelming and deeply troubling. Multiple large-scale, high-quality studies, including those published in the New England Journal of Medicine, have compared this exact surgery to a placebo or sham surgery. The results are stark. For degenerative conditions like osteoarthritis, the surgery is no more effective than the placebo. This is where the risk becomes magnified. You are not choosing between a real procedure and doing nothing. You're choosing to accept the very real risks of an invasive surgery in exchange for a benefit that is statistically indistinguishable from a fake operation. And the risks are not trivial. Every time a surgeon cuts into the body, there's a risk of a deep joint infection that can be incredibly difficult to treat. There's a risk of blood clots forming in the leg, which can travel to the lungs and become life-threatening. This is the grim calculation that the wear and tear narrative pushes people like Margaret and Arnold towards, accepting the possibility of catastrophic harm for the probability of a placebo-level benefit. It's a path that focuses entirely on fixing the picture on the MRI without ever asking if that picture is even the real problem. But what if the entire premise is wrong? What if the most powerful solution isn't about removing damage from the joint, but about restoring function to the entire system? The alternative is to shift our focus entirely, to move our attention from the static black and white picture of the joint to the dynamic, living performance of the entire system. The question we should be asking is not, what does my MRI look like, but the far more important question, how do I move? Imagine for a moment if Margaret's consultation had started differently. Instead of being led to a light box to view an image of her internal gray hair, what if she had been asked to perform a simple bodyweight squat? What if a professional had watched her walk down the hallway and noticed that with every single step, her foot flattened excessively and her knee dove inwards toward the other? That single observation of her movement pattern would have been infinitely more valuable than her MRI report. It would have told a completely different story. The MRI showed her a seemingly irreversible problem of structure, a part that was worn out, but her movement revealed a solvable problem of function. It pointed towards a clear path for improvement, not a life sentence of decline. This is the entire key. This simple change in perspective stops us from seeing the knee as a broken part that needs to be fixed or replaced, and starts us seeing it as the place where a deeper problem is finally making itself known. This is the crucial first step in understanding that your knee is not the source of the issue. This is how we begin to see the knee for what it truly is, the victim, not the culprit. Now, this is a crucial distinction. I am not saying your pain isn't real, or that the damage shown on an X-ray is imaginary. The pain is absolutely in your knee. The inflammation is there, but that pain is a consequence, not a cause. It's the end of a long chain of biomechanical events, not the beginning. Let's go back to our joint-by-joint framework. We established that the body is an alternating stack of stable and mobile joints. The knee, by its very design, is a stability joint. It's a simple, elegant hinge, built primarily to bend and straighten with incredible strength and reliability. It is caught directly between two of the most complex mobile joints in the entire human body, joints that are supposed to handle a huge range of motion, the ankle below and the powerful ball and socket joint of the hip above. When the ankle loses its mobility and becomes stiff, or when the hip loses its strength and range of motion, they fail to do their jobs. They fail to absorb shock, and they fail to rotate properly. But your body still needs to create that movement to get you from point A to point B. So it steals that movement from the only place it can, the knee. Suddenly, this simple hinge is caught in the crossfire. It's being asked to absorb rotational forces it was never designed to handle. It's being forced to wobble and shift side to side, putting immense stress on the cartilage and ligaments. The knee is essentially being bullied by its neighbors. Over time, this abuse leads to breakdown and pain. This is why treating only the knee is so often a losing battle. To make this idea perfectly clear, let's move away from anatomy for a moment and think of it in simpler mechanical terms. Think of it like this. The knee is a simple door hinge. Its only job is to swing open and close smoothly, thousands of times a day. It is a masterpiece of simple, strong design. The hip above it is the door frame, and the ankle below it is the floor that the entire frame is built upon. Now, what happens in an old house if the foundation settles and the floor, our ankle, becomes crooked and uneven? Or what if, over time, the house shifts and the wooden door frame, our hip, warps and goes out of square? What happens to the simple little hinge caught in the middle? It starts to creak. It groans. It begins to grind because it's being pulled and twisted in directions it was never designed to tolerate. The metal fatigues and wears out prematurely. Now, you could go to the hardware store. You could buy the most expensive lubricant and spray it on that hinge every single day. That might quiet the noise for a little while. You could even hire a carpenter to come in and replace the hinge entirely with a brand new state-of-the-art model. But if you never fix the crooked floor and the warped door frame, what is the inevitable fate of that new hinge? It will suffer the exact same fate. The grinding will return. The stress will accumulate. The breakdown is not a matter of if, but when. This is the most important concept to grasp in this entire video. Treating the knee with pills, injections, or even surgery without first rigorously assessing the function of the hip and the ankle is like endlessly replacing the hinge without ever once checking if the door frame is square. It's an approach focused entirely on the site of the symptom, and it is doomed to fail because it ignores the source of the stress. This isn't just a metaphor. It is the precise mechanical reality that dictates the health of your joints. And it's the exact reason the standard approach so often fails our friend Arnold. Let's go back to Arnold. His doctor focused entirely on the image of the grinding, worn-out hinge, prescribed a treatment plan that was perfectly logical within that narrow view. He was given a cortisone shot directly into the joint, the equivalent of spraying lubricant on the hinge. He was told to take anti-inflammatory pills, a way to muffle the loud, annoying noise it was making. Every action, every prescription was aimed squarely at the knee. But here is the question that exposes the deep, frustrating flaw in this entire approach. During that consultation, did anyone ever test his hip mobility? Did a single healthcare professional measure his ankle's range of motion? Did anyone watch him walk down the hallway to observe the subtle patterns of his movement, to see if the door frame was warped or the foundation was crooked? In the vast majority of cases like Arnold's, the answer is a resounding no. And because of that, his treatment plan was doomed from the start. It was a well-intentioned but ultimately futile effort aimed squarely at the victim. The real culprits, a likely stiff and weak hip, were left entirely unaddressed. They were never questioned, never identified, and left completely free to continue their silent, relentless abuse on his knee joint, day after day. This shift in thinking from the site of the pain to the source of the stress is everything. It's the difference between managing a problem and actually solving it. We're covering a lot of ground here, and I want to make sure this is truly landing. Does this analogy of the victim and the culprit make sense? Because internalizing this one idea is the single most important step toward breaking free from chronic pain. It fundamentally changes where we look for answers. So I'm genuinely curious to know if it's clicking for you. If this new perspective is resonating, if that light bulb is starting to go on, please do me a quick favor. Just type the number 1 in the comments below. It takes only a moment, and it lets me know that this crucial framework is connecting with you and providing real value. I'll be looking through those responses. Thank you for that. All right, now that we've established our framework, that we're looking for culprits, not just treating victims, it's time to unmask our first major suspect. This is the one I asked you to pay special attention to at the start of our investigation. We're going to travel down the kinetic chain to a place most people would never think to look when their knee hurts. All right, let's reveal our first hidden culprit. Point number 3, the forgotten foundation, which is, perhaps surprisingly, your ankle. It seems so distant from the knee, doesn't it? But the connection is direct, mechanical, and powerful. For your knee to be healthy, your ankle must be mobile, specifically in one critical movement called dorsiflexion. That's simply the ability to bend your foot upwards, bringing your toes toward your shin. You do this thousands of times a day without thinking. This movement is absolutely essential for absorbing the shock of every footstep. It allows your knee to travel forward properly over your foot during basic activities like walking down a slope, climbing stairs, or squatting down to pick something up from the floor. But when a lifetime of stiff shoes or an old, unrehabbed injury robs you of that mobility, your body's forced to steal that movement from somewhere else. This seems like a small problem, a few degrees of lost motion. But how much of a difference can it really make? When researchers created studies to measure this exact effect, the numbers they found were not small at all. In fact, they're genuinely shocking. Research from sources like the Journal of Sport Rehabilitation has weighed out the dramatic consequences in stark, mechanical terms. When ankle dorsiflexion is restricted, even by just a few degrees, the ground reaction forces, the impact that comes up from the floor with every single footstep, can no longer be absorbed by the ankle's natural rocking motion. That force has to go somewhere. It gets shunted directly upwards like a shockwave into the knee. This forces the knee into what's called dynamic valgus, that destructive inward collapse we mentioned earlier. It's the visual sign of a system under stress. And the numbers here are staggering. One key study showed that artificially restricting ankle motion during a simple squat increased the torque and sideways stress on the knee by as much as 30%. Let that number sink in for a moment. 30%. Now translate that from a laboratory experiment into your daily life. Imagine every single step you take, every time you get up from a chair, every stair you climb. Imagine doing all of that with up to 30% more destructive, grinding, sideways force being applied to the delicate cartilage inside your knee joint. This isn't a one-time injury. This is a slow, relentless process of mechanical abuse, repeated thousands of times a day for years and years on end. This is how a knee wears out. It isn't a mysterious function of the calendar. It's not about your age. It is a predictable outcome of bad mechanics, starting from the ground up. The forgotten foundation crumbles and the stress fractures travel all the way up the building. But how exactly does a stiff ankle create this specific destructive wobble in the knee? The mechanics of this cascade are both fascinating and crucial to understand. This is the stiff ankle cascade, and it is one of the most common and most overlooked drivers of knee pain in adults over 60. It begins silently, often decades before the pain starts. A lifetime of wearing rigid, supportive shoes that act like a cast for your feet. A minor ankle sprain in your 30s that never fully healed, leaving behind a subtle web of scar tissue. Or simply a gradual loss of movement from years spent sitting more and walking on varied terrain less. The ankle, a joint designed for a beautiful, complex range of motion, becomes stiff, locked, and functionally useless. But your body, in its infinite wisdom and desperate need to function, still has to get that forward motion from somewhere. When you take a step, your knee needs to be able to travel forward over your foot. If the ankle joint refuses to bend to allow this, your body improvises. It finds the path of least resistance. It forces the arch of your foot to collapse excessively, a condition called overpronation. You can almost picture it. The foot, instead of acting as a strong and stable lever, flattens and splays out against the ground. This is not a harmless compensation, because when the arch collapses, it causes the lower leg bone, the tibia, to rotate inwards. It's a direct mechanical consequence. But here is where the destruction truly happens. The upper leg bone, the femur, which is connected to your hip, does not follow along at the same rate. You now have a situation where the bottom of the knee joint is being twisted inwards while the top of the knee joint is trying to stay straight. The result is a subtle but relentless twisting and grinding force right through the center of the knee. It's like trying to open a stubborn jar. If you hold the bottom steady while twisting the lid, all the force goes into the threads. In your leg, that force is being driven directly into the soft cartilage and the stabilizing ligaments of your knee with every single step you take. This isn't wear and tear from age. This is a specific, destructive mechanical stress born from a problem one joint away. Now you can see why no amount of knee-focused treatment can ever fix this. You can rub creams on the knee, get injections to cool the inflammation, or take pills to numb the pain, but none of those actions will ever unstick the ankle. None of them will stop the lower leg from twisting with every footstep. The only true solution is to address the root cause, to restore mobility to the forgotten foundation. And this is where the story turns from frustrating to hopeful. Because often, a few minutes a day of simple, targeted stretches and mobility drills aimed at the ankle can lead to a dramatic, almost unbelievable reduction in chronic knee pain. It feels like magic, but it's just mechanics. By giving the ankle back the mobility it lost, you relieve the knee of its compensatory burden. You stop the grinding. You finally fix the crooked foundation so the hinge can swing freely again. It's a profound reminder that the most powerful solutions are often not the most complex or expensive ones. However, the stiff ankle is only one of the two primary culprits that torments the knee. The foundation below can be crooked, but the frame above can be just as weak and unstable. Now let's move up the chain to the other primary culprit, and frankly, for the majority of people, this is the big one. Point 4, the powerhouse above, your hip. The hip is a marvel of engineering, a powerful ball and socket joint designed for a massive range of motion in all three planes. It should be the most mobile and powerful joint in your lower body. But for knee health, its most crucial role is controlled by a group of muscles on the side and back of your hip, particularly one called the gluteus medius. These are the unsung heroes of lower body mechanics. Their entire job is to act as a stabilizer, to keep your thigh bone, the femur, pointing straight ahead, and to prevent it from rotating and collapsing inwards when you walk, stand, or climb stairs. They are the guardians of your knee's alignment. And I want to pause here, because I understand that for many of you, this might feel counterintuitive. You're thinking, Dr. Dean, my hip feels fine. It's my knee that's on fire. And you are absolutely right to feel that way. This is one of the most common and valid points of confusion, and it's why this issue is so frequently missed. The hip can be profoundly weak and dysfunctional without ever sending a single pain signal. Its failure is often silent. The pain is the knee's job. It is an excellent alarm system. But stability is the hip's job. And when the muscles of the hip are weak, they can no longer properly control the top of your femur. With every step, the powerful thigh bone is allowed to drift and rotate inwards, causing your knee to collapse into that same destructive valgus position we saw with the stiff ankle. You can have a perfectly healthy knee joint, but if the bone above it is out of control, the knee will be forced into a damaging position, step after agonizing step. This fundamental misunderstanding, this failure to look one joint above the pain, isn't just a missed opportunity for a real solution. It often leads to a bizarre and deeply frustrating situation in conventional treatment, an ironic side effect where the therapy itself can reinforce the very mechanical fault it's trying to solve. Here's the great irony. What happens when a person like Arnold with a painful knee is finally sent to physical therapy? He arrives full of hope, ready to do the work. And very often he's directed to a specific piece of equipment, the leg extension machine. He sits down, hooks his ankles under the pad, and methodically straightens his knee against resistance over and over again. He can feel the burn in his quadriceps, the big muscles on the front of his thigh. It feels productive. He's getting stronger. His chart will show that his quad strength has improved by 20%. By all conventional measures, the therapy is a success. And yet, his knee still hurts when he walks. This is the deeply frustrating trap so many fall into. The problem is rarely weak quads. The problem is almost always weak hips. When those crucial hip stabilizer muscles fail to control the femur, the knee is forced to collapse inwards. The leg extension machine does absolutely nothing to fix this. It's like discovering a fire in your house and responding by meticulously polishing the doorknobs on the opposite side of the building. You're improving something, yes, but you are completely ignoring the actual crisis. The ironic side effect is that by focusing only on the knee, you can spend months in therapy, get demonstrably stronger quads, and still have the exact same underlying mechanical fault that's causing the pain in the first place. You're diligently strengthening the victim, making it a stronger victim, while the true culprit, the weak hip, is left completely unaddressed, free to continue its destructive rampage. This isn't just ineffective, it's profoundly disempowering. It can lead a person to conclude that even physical therapy can't help them, reinforcing the false narrative that their knee is simply worn out and beyond repair. But what if the solution wasn't found in a gym machine at all? What if the truly superior solution was simpler, required no special equipment, and addressed the culprit head-on? That solution is often breathtakingly simple and requires no medication, no injections, and no surgery. The best solution is simply to strengthen the hips. A robust body of research, including a key paper by Dr. Christopher Powers in the highly respected Journal of Orthopedic and Sports Physical Therapy, has established this powerful link beyond any reasonable doubt. Studies have shown that strengthening the hip abductor muscles, those on the outside of your hip, and the external rotators is one of the single most effective ways to treat chronic knee pain, especially the common type that occurs around the kneecap. It's not a theory, it's a proven mechanical fix. We're not talking about complex, heavy weightlifting. We're talking about simple, targeted exercises that anyone can do at home, often with just their own body weight or a simple resistance band. Exercises like clamshells, side-lying leg raises, and banded side steps can be utterly transformative because they directly address the root cause of the knee's distress. They teach the powerhouse of the hip to do its job again, relieving the knee of its unfair burden. This is exactly what happened with Margaret. After her initial devastating diagnosis pushed her into a state of fear and inaction, a friend convinced her to see a different kind of physical therapist, one who focused on movement, not just images. This therapist barely glanced at her MRI report. Instead, he watched her walk. He tested her strength, and he quickly identified profound weakness in her hips, particularly on the same side as her painful knee. For the next 6 weeks, Margaret's program was simple. She did nothing but a handful of gentle hip-strengthening exercises 3 times a week in her own living room. And slowly, then all at once, something remarkable happened. The pain that had plagued her for over a year, the pain that had stolen her joy and shrunk her world, began to fade. And then it vanished. She didn't need a new knee. She didn't have the knee of a 90-year-old. She just needed stronger hips. Her story is a powerful testament that the most effective solution is often to look one joint above the pain. But this raises a critical question. The hips are the powerhouse, yes. But what anchors that powerhouse? What provides the stable platform that allows those hip muscles to fire effectively in the first place? This brings us to the final and perhaps most fundamental piece of the puzzle, the one that ties your entire upper and lower body together, and the one that is almost universally overlooked. It's time to talk about the core of the problem. Now, when I say core, I don't mean the six-pack abs you see on magazine covers. In terms of human function, the core is a deep, complex system of muscles in your trunk and pelvis that create a stable platform for everything else. Think of your pelvis as a shallow bowl of water. If your core muscles are strong and engaged, that bowl stays perfectly level as you move. But if those muscles are weak, that bowl is constantly tipping, sloshing, and spilling with every step. And what is attached directly to that unstable, wobbly bowl? Your leg bones, your hips, your femurs. You cannot have a stable knee without a stable pelvis. It's a mechanical impossibility. If the top of your femur is attached to an unstable, wobbly platform because of a weak core, the bottom end of it at your knee will be thrashing around uncontrollably with every step you take. This leads directly to a kind of catch-22, a devastating paradox, especially for those like Arnold who are being told that surgery is their only remaining option. A surgeon can be a master of their craft. They can go in and install a perfectly aligned, state-of-the-art artificial knee, an engineering marvel. But they are putting that flawless new part into a system that still has a faulty foundation. If the patient has a weak core and weak hips, their fundamental movement patterns will not magically change after the surgery. They will continue to walk with that same knee-collapsing gait that destroyed their natural knee in the first place. And here is the critical fact that is so rarely discussed in the pre-op consultation. This is a major reason why, according to high-quality studies published in journals like Clinical Orthopedics and Related Research, up to 20% of people are dissatisfied with their total knee replacements. 1 in 5. They go through the pain, the lengthy rehabilitation, and the expense, only to find that they are still in pain or still limited in their function. The tragedy is that the surgery itself wasn't a failure. The hardware is perfect. The implant is a modern miracle. But the software, the brain's ingrained motor program for how to walk, is still buggy. The new, expensive joint is immediately subjected to the very same dysfunctional forces that caused the original one to wear out. The operation replaced the damaged part, but it couldn't fix the broken movement that caused the damage in the first place. This isn't a rare complication. It's a predictable outcome of focusing on the victim while ignoring the culprits. It applies to Arnold. It applies to Margaret. I could tell you another story here. I could introduce you to a specific person who, after years of failed treatments and facing the prospect of surgery, finally eliminated their knee pain with nothing more than 30 days of simple core exercises. I could describe their shock, their relief, the simple joy of walking down a flight of stairs without thinking about it for the first time in a decade. But I'm not going to. Because to reduce this to a single tidy anecdote would be to do you a profound disservice. It would frame this as a lucky break, a special case, a feel-good story. And it is not. This is a fundamental, non-negotiable law of human biomechanics. This law applies to Arnold. It applies to Margaret. It applies to the elite athlete at the peak of their career, and it applies to the retiree who just wants to tend their garden without a constant grinding ache. Your body is a kinetic chain. This is not a metaphor. It is a mechanical reality. The stability of your core is the anchor point that allows your hips to function correctly. The stability of your hips is the only thing that allows your knee to track straight and true. One link in that chain fails and the entire structure is compromised. This isn't a theory. It's not a wellness trend. It is engineering. It's physics. It is as reliable and predictable as the law of gravity. A weak and unstable core will over time lead to dysfunctional hips, which will in turn place destructive, unnatural stress on the knee. It is a straight line of cause and effect. So, we have deconstructed the problem. We've identified the culprits. Now, how do we turn this knowledge into action? At the beginning of this video, I promised to equip you not just with information, but with a new way of thinking and a set of tools to find lasting relief. And I am going to deliver on that promise right now. I am not going to give you a generic list of exercises to follow. Frankly, that would be irresponsible without a personal assessment, and it would violate the entire principle of this channel, which is to empower you, not just prescribe to you. Instead, I want to give you something far more valuable and enduring, a framework. a simple 5-point protocol you can use to begin assessing your own body and, more importantly, to have a more intelligent, productive conversation with your doctor or physical therapist. I'm going to give you 5 empowering questions to ask. I encourage you to pause the video, grab a pen and paper, or open the Notes app on your phone. Write these down. These questions are your new roadmap. They shift you from being a passive patient with a painful knee to an active detective investigating your own case. They are designed to uncover the hidden culprits we've spent this entire video unmasking. Are you ready? Let's begin with the first question, which starts our investigation right where the evidence so often points, at the forgotten foundation. Question 1 is the ankle test. I want you to ask yourself, can I perform a simple body weight squat without my heels lifting off the ground? Here's how you check. Take off your shoes and stand with your feet about shoulder width apart, toes pointing mostly forward. Now, keeping your back as straight as you comfortably can, try to squat down as if you're about to sit in a very low chair. Go as low as you can without pain. The only thing you're watching for is your heels. Do they stay flat on the floor or do they immediately pop up as you descend? If your heels lift off the ground, you have just received a powerful piece of information. It is a very strong sign that you have limited ankle dorsiflexion. You've just identified our first potential culprit, the forgotten foundation, in your own body, with a test that took less than 30 seconds. This is the first clue in your investigation. Question 2 is the hip stability test. For this one, you'll want to stand in front of a mirror. Ask yourself, can I stand on one leg for 30 seconds without my hip dropping or losing my balance? Stand up straight and gently lift one foot off the ground. Now, watch the hip of your standing leg very closely in the mirror. Does it drop down to the side, away from the leg that's in the air? This is called a Trendelenburg sign. Are you wobbling uncontrollably, your arms flailing to keep your balance? This simple test is a direct window into the strength and function of your gluteus medius, that critical hip stabilizer muscle we talked about. A dropping hip or a constant struggle for balance tells you that the powerhouse above your knee is not doing its job. The guardian is asleep at its post, leaving your knee vulnerable and unprotected. Question 3 is the asymmetry question. As you perform these simple tests, or even as you just go about your day, ask yourself, when I walk upstairs or stand on one leg, does one side of my body feel significantly weaker, tighter, or less coordinated than the other? Most of us have a dominant side, but what we are looking for here is a glaring imbalance. Does your left hip feel much weaker than your right? Is your right ankle dramatically stiffer than your left? These significant asymmetries are huge red flags. Your body craves balance, and when it can't find it, it creates damaging compensations. A major imbalance between your left and right sides is often the hidden driver behind a chronic one-sided knee problem. Your pain is your body's way of telling you that one side is doing all the work while the other is getting a free ride, and the knee is paying the price for that dysfunctional partnership. Question 4 is the muscle activation question. This one requires you to become more aware of what you feel as you move. The next time you climb a flight of stairs, ask yourself, where do I feel the work? As you push off each step, is the burning sensation and the feeling of effort located almost entirely in the front of your thighs, your quadriceps? Or can you genuinely feel the powerful muscles in your buttocks, your glutes, engaging and doing the heavy lifting? For many people, this is a revelation. They realize they've been climbing stairs using only their smaller, less efficient quad muscles for decades. If you are not consciously using your glutes, the largest and most powerful muscles in your entire body, then you are not using your body as it was designed. You're asking the knee joint and the muscles around it to handle forces that should be managed by the powerhouse in your hips. This is a correctable software problem, a faulty motor pattern that can be retrained with focus and intention. Finally, we arrive at question 5. This isn't one you ask yourself, it's the one you take with you into the clinic. This is the professional assessment question. The next time you speak to your doctor or physical therapist, I want you to ask this, respectfully but firmly. Before we focus only on my knee, can we please assess the mobility of my ankles and the strength and function of my hips and core? This single question changes the entire conversation. It signals that you are not a passive patient willing to simply chase the symptom. It shows that you are an informed, engaged partner in your own health and that you are looking for a root cause solution, not just another temporary patch. It reframes the goal from how do we make the knee quiet to how do we fix the system so the knee no longer has to scream. Armed with the answers from these first 4 questions and the courage to ask the 5th, you have a completely new framework for understanding your pain. You're no longer just a person with a bad knee, you are an investigator who has gathered crucial evidence. And the response you get to that 5th question will tell you everything you need to know about whether you're in the right place to find a real solution. A good physician or physical therapist will welcome these questions. They will see them not as a challenge to their authority, but as a sign that you are an engaged and thoughtful partner in your own care. They will agree, without hesitation, that assessing the entire kinetic chain is not just a good idea, but an essential part of any intelligent diagnosis. Their response will make you feel heard, validated, and hopeful. But I also need to give you a clear red flag to watch for. If you ask these questions and your provider dismisses them, if they wave a hand and say, "That's not relevant, let's just focus on your knee x-ray," that is a powerful signal you may not be in the right place. That response is not a reflection on you or the validity of your questions. It is a sign that they are still trapped in the old, outdated model of chasing the symptom. It tells you that their practice is built around identifying the victim, not finding the culprit. You have the right, and I would argue the responsibility to yourself, to seek a second opinion from someone who understands that the body is an interconnected system, not a collection of isolated parts. Because making that choice is about more than just finding a better treatment for your knee. It's about choosing a better story for your future. It's about a fundamental shift in how we view our bodies as we age. The wear and tear narrative is a story of passive decay. It tells us that we are victims of time, that our bodies are lemons with an expiration date, and that our only hope is to find a good mechanic to replace the parts as they inevitably fail. This story places you in the role of a passenger. You're told that pain is a destination you are guaranteed to arrive at, and your only choice is how you manage the discomfort when you get there. It is a story that ends in resignation. It's the story that was handed to Arnold, and it's the one that almost trapped Margaret. The joint-by-joint approach tells a different story entirely. It's a story of active adaptation. It says that your body is a resilient, intelligent system, and that pain is not an endpoint, but a signal, a valuable piece of information that is guiding you toward the precise place where the system needs your support. It sees the body not as a car to be serviced, but as a garden to be tended. You don't replace a plant that's wilting. You look to see if its soil needs water, if its neighbors are crowding its roots, or if it needs more sunlight. You address the environment to restore the health of the organism. This story puts you back in the driver's seat. It places you in the position of a thoughtful gardener. It replaces the fear of a failing part with a curiosity about a struggling system. It replaces the helplessness of a bad diagnosis with the power of a clear direction. It's the profound difference between managing a decline and cultivating longevity. This is the entire philosophy behind the longevity lens we use here. The goal isn't just to silence a symptom or to get a better-looking X-ray. The goal is to restore the freedom that the symptom has taken from you, the freedom to move through the world with confidence and joy, to stay independent, and to remain an active participant in your own life and the lives of those you love. If this approach of looking for root causes and empowering patients resonates with you, then I invite you to subscribe to Keystone Health and join our community. We release deep dive videos just like this one, designed to give you the evidence-based tools you need to navigate your health with confidence and preserve your quality of life for years to come. Our entire mission is to apply this longevity lens to the health challenges that matter most, shifting the focus from managing decline to actively cultivating health. So if you believe in that mission, click the bell icon so you don't miss our next investigation. And to continue the conversation, let's go back to those 5 empowering questions. They aren't just tests, they are the first few sentences in a new story you can start writing about your own body, a story based on curiosity instead of fear. In the comments below, I'd like you to share which one of those self-assessment tests was the most surprising or revealing for you. Was it the ankle test and seeing your heels lift off the ground with a new understanding of what that might mean? Or was it the hip stability test, feeling that unexpected wobble and realizing for the first time where the instability might truly be coming from? Perhaps it was the muscle activation question and the sudden realization that you haven't truly felt your glutes engage on the stairs in years. Sharing your aha moment is more than just a comment. It's a small act of generosity. Your moment of discovery, the thing that just clicked into place for you, might be the exact spark that helps someone else in this community, someone who feels just as stuck as Arnold did, to finally start their own journey toward relief. Reading these shared experiences is how we move from feeling like isolated patients to becoming part of a collective search for better answers. Your story matters. Thank you for watching, and be well. After seeing how your knee pain could actually start in your ankles or hips, what's the one old age excuse you're now ready to challenge? Tell me in the comments below. I read and reply to every single one. In our next video, we uncover how a common ringing in the ears could actually be a hidden message from your heart. Subscribe and turn on notifications so you don't miss the truth that could be hiding in plain sight. Like this video if you see the pattern, and share it with someone who needs to see it too.